Good afternoon, everyone. My name is Erin. I'm the Vice President of Communications and Public Affairs. Happy to moderate today's virtual town hall on Tuesday, January 26th, specifically talking about vaccine distribution and what's occurring province-wide, well, really nationally and in Ontario in response to the shortage of vaccine. We have a number of different people here to give us a little bit of insight on this topic, and we'll pause for questions at the end to the best of our ability. If we don't get your questions in, we have another webinar on Thursday, but we'll do our very best today. First, I'd like to call on our President and CEO, Rob McIsaac, to let us know exactly what we'll be hearing about today and kick us off with a few words. So Rob, over to you.
Yeah, thanks very much, thanks very much, Erin, and hello, everybody. We appreciate the fact that you've been able to join us on short notice. We just felt it was important that we gather everyone in light of the vaccine news that got shared yesterday by the province, and to try to provide some clarity as to what exactly this will mean for Hamilton Health Sciences staff and physicians. You know, we've certainly learned over the course of the pandemic is that we can do lots of planning, but it can change on a daily basis. And that's certainly the case with respect to our planning to get the vaccine out to everybody as soon as possible. As you know by now, HHS has received direction from the province to respond to the reduction in shipments of the Pfizer vaccine. I want to be clear that, the actions we're rolling out today, and in fact, the way in which we've been proceeding to date has been very much faithful to the province's directions to us around vaccine rollout. We are meeting with the province regularly, as recently on the weekend and again last night, with the ministry and General Hillier, who is leading the initiative around vaccine distribution. When vaccines are available for distribution is entirely dependent on the supply chain, which starts internationally and is really managed principally by the federal government based on their negotiations with pharmaceutical companies around the world. I know that everybody is anxious to receive the vaccine, and our goal remains to vaccinate everyone at Hamilton Health Sciences as soon as we possibly can, but of course, dependent on our ability to actually receive vaccine here in town. As always, I'm deeply grateful to each of you for traveling this very long, difficult road together and in caring for our patients and in caring for each other during what is really the biggest challenge of our generation. You can see the agenda for today's meeting in front of you. So we'll talk about where we've been in terms of vaccine distribution, the provincial decisions and plan, and what's next for HHS, and some technical guidance around dosing. As always, we'll have some time for Q&A. So I'll turn it over to Dave McCaig, Bruce Squires, and Les Gauthier, and Dr. Smale to share the details about the changes related to vaccine dosing and distribution.
Okay, thank you very much, Rob. And I'll start off. And my job is really just talk about what we've done so far. So probably want to get through that most quickly. I do want to highlight, as you've described, Rob, that although we've done the work to set up our vaccine clinic and to vaccinate a tremendous number of folks collaboratively with HHS, St. Joe's, Hamilton Public Health, and a number of other organizations, the fact is that this continues to be heavily directed and controlled by the province, including by the provincial task force under General Rick Hillier. So our initial direction for sure was to use our clinic to vaccinate healthcare workers and essential caregivers in long-term care and retirement homes, but we quickly had the opportunity to expand that to include hospital workers in the highest risk areas according to the provincial framework. So if I can go to the next slide, please, Les. So our clinic has now operated for a little bit in excess of a 1-month period. And you can see here that a tremendous number of individuals across Hamilton have received their first dose of either the Pfizer, or in the case of some residents, the Moderna vaccine, and a fair number have received their second dose. So that's distribution so far. And I just do want to take the opportunity to, in highlighting that that's a very significant number of individuals that have received the vaccine. There are some areas of the province, a small number that might be further along. There are a significant number of areas of the province that are not as far along as we are in Hamilton. And that's really thanks in large part to the great work on part of so many individuals across our partners, but in particular within Hamilton Health Sciences, as we've set up that clinic and operated it. So certainly my personal thanks to those individuals. I'll pass it over now to EVP Dave McCaig.
Thanks, Bruce. So, and first of all, yeah, I'd just like to highlight that the clinic was extremely successful, and a lot of effort went into that. And you can be assured that effort went in on behalf of Hamilton's healthcare workers. At the height of the available supply, we were the second largest single site vaccine clinic in Ontario. So great job, Bruce and team. So why is the plan changing again? I mean, it's not probably very new news if you're at all reading the press, but there is significant supply chain issues with Pfizer as they retool their plant to be able to increase production for global demand. We were informed by the province that we could expect no new doses, no new vaccine shipments to Hamilton until mid-February. There's some good news from the perspective of Moderna, which is being used predominantly or exclusively for long-term care residents, et cetera, which we'll cover in the next slide. But that supply is not affected by the interruption, so that at least is still coming to Hamilton as expected. Due to the Pfizer shortage, the provincial actions that have been taking place, as you can see here, first of all, there was a province-wide review of current inventory of vaccines for both vaccines, Pfizer and Moderna, a forecast all the way through to when all the second doses would be needed for every clinic in Ontario. And certainly the provincial actions have been focused on vaccinating all long-term care residents and high-risk retirement home residents. So that direction is going to continue, as you'll see on the next slide, please. So certainly with the prevalence of number of outbreaks in long-term care homes still is the highest risk factor assessed by the province. So they continue to and wish to actually accelerate immunization of long-term care and high-risk retirement home residents across Ontario. That means that is going to be the 100% focus of any new doses is going to go to those populations. This may also include some ALC patients that are designated to go to long-term care so that when they arrive, they're already vaccinated, and that remains to be seen exactly how we would partner with public health to accomplish that. For Pfizer long-term care, high-risk retirement home residents, the dosing pattern is going to change. So they will be within 21 to 27 days. For all other populations, including healthcare workers, the second dose interval will be extended to as much as 42 days. For Moderna, the maintain a 28-day interval is still playing out as that supply chain, again, is still moving along as it was expected. I guess the last point would be, and actually before I get to the last point, be assured later in this discussion, there'll be some explanation around what it means to have the second dose beyond the original targeted 21 days for Pfizer. The province may reallocate doses across Ontario to ensure that anyone who has had a first dose receives it within the 42 days. At the moment, we have not been informed that any such reallocation out of Hamilton will occur. So we do know what we have in place, the second doses, when we need to give them, and when we need to receive more by mid-February is well understood. So I think that kind of covers the basics of the provincial direction. It has been a lot of effort and partnership with public health and others to make sure we understand where things are going, and also always keeping in mind the best interests of our staff and managing this rather complex environment that we find ourselves in. So always wanting to make sure we get second dose in arm as soon as possible. So with that, I'll turn it over to Les, who will take us through some of the specifics of what that means for Hamilton Health Sciences.
Okay, so thank you, Dave. I think I'd like to start and just take a moment to acknowledge that we know for everybody listening who has yet to get a first or second dose, that some of the messages this morning are disappointing. And we all share in that, but equally, I want to reassure people that Hamilton Health Sciences is advocating at the provincial table and optimistic when our supply chain is back, that we will be right back celebrating all of the success that we have had in the vaccination clinic. So I put this in the context that right now our work has paused, and it is paused, but we have great foundation to go back when we resume. So key messages that as of today, all first dose, actually as of last week, all first doses of vaccines to be administered to healthcare workers are paused. And the provincial definition of a healthcare worker, so frontline staff, physicians, residents, and learners. So across the board in the province, all first line doses have been paused. As of the end of day today, any second dose that has been scheduled is now paused and will be administered somewhere between 35 and 42 days after your first dose. So I'm sure those listening and reflecting on the numbers Bruce has shared, that is an awful lot of people who will be rescheduled by the vaccination clinic. The third important piece of information is that people understand the sequencing order by which both the hospitals and the communities are moving forward. We're all aligned to the provincial document, and it's titled here, people can search it. It's guidance for prioritizing healthcare workers for the COVID-19 vaccine. The work that has been done by HHS in collaboration with St. Joe's is very much aligned to that provincial document in terms of who is sequenced first. And again, the message here, it's a matter of how we sequence our teams. There will be enough vaccine in the province to vaccinate everyone who wishes. This is how we're approaching the sequencing. So that takes us to what are we going to do for the time that we are paused? And one important piece of work is we know we have over 500 people waiting in sequence 1. So we're going to go back and do a review of those people who are listed. We are specifically looking at people who have sequenced themselves in group 1. Are they the right people? So that once we start back up again, that we can be really confident the people that will get needles in arm first are the people who are most aligned to the provincial direction for sequence 1 group. So it will be a check, and this work we're doing with St. Joe's. We have the leadership of Dr. Helene Flagiol from a physician perspective and Dr. David Russell at St. Joe's, who are also going to partner with us as we start to look at who's put themselves into which part of the sequence. I remind people on the next slide, please, of how the province has asked us to sequence. So group 1 is those individuals who are the highest risk of COVID exposure. So it's not the question of, do you have a risk of COVID exposure? It's really self-reflecting. Are you the highest risk in the organization? And the highest risk is being defined as people who are more than 60% of the time working with COVID positive patients or highly probable. So that it's not, did you have a COVID patient on your unit? Could you have COVID in your unit? It's, are you our highest organizational risk? The second sequence for people are those teams that are dealing with our most vulnerable patients, those patient populations who are most at risk if they were to get COVID. Dave has already stated we are starting some work and planning on how we're going to go out and actually vaccinate some of our high-risk patient populations, most specifically our long-term care patients, who we know will be leaving our organization and going to the care of long-term care. So we're waiting for provincial direction that is our priority, but we're going to have the work ready to go when we receive that direction. Our third group is where we estimate at least half of the team at HHS belongs. And these are our teams who every day come to work in clinical worlds. They're patient facing, they have their appropriate PPE to protect them. And with that, their independent PCRA that you're doing to make sure that for the patient you're caring for that day, you believe you've selected the right PPE. This is group 3. So there still is COVID risk in group 3. It's just not our highest organizational risk. And then group 4 represents all other hospital workers, particularly those individuals who are not forward facing consistently all day long in our work. And as Rob has previously shared with people, for sure the majority of HHS leaders see themselves within group 4. So what do we need from people in the next few weeks while we are paused? One is we would really like you to take the opportunity to review the FAQ document that is posted. We are working to refine that sequencing document, and there will be a final version that will come out. Right now, there's a version that was posted a week ago that's there for your reference. I do ask people to take a moment and reflect. If you've sequenced yourself in group 1, do you believe you are in the highest risk group in the organization for COVID? Not are you a risk, are you the highest risk group? I say in addition to that, we are going to be going through the list and putting a lens to also looking to see who's in sequence group 1. And then again, as soon as the vaccines are available, that awesome clinic that people were so proud of, and people telling us that across the organization, people saw this as just awesome. That clinic is going to be there and ready to be turned back on as soon as the vaccine supply is here and we can start putting needles back in arms. So again, the goal we're still working to is to vaccinate everyone who wishes a vaccine. Obviously, we need the drug in order to do that. I do also like to remind people, and I know Fiona, who's going to speak next, if you have any hesitancy to getting the vaccine, you have time to reach out and really do some good personal investigating work or consult with your infectious disease colleagues around the vaccines. Our wish is that our entire team will accept it and we'll be ready to put needles back in arms as soon as the supply chain is there. So with it, I think probably the most important person to reassure people about some of the provincial direction today is Dr. Smale, and I'm going to hand it over to Fiona.
Thank you very much. Thank you very much, Les. So I fully understand the sort of unease and distress that many of you are feeling given this information that what was anticipated to be your second dose within a week or two, with the expectation that a week after that you would really have protection against COVID disease, is now put on hold for a longer period of time. And so what I want to explain is that from my perspective as an infectious disease physician and immunologist, somebody who has a lot of experience with vaccines, that I am quite confident that the delay of up to 42 days will not significantly impact the final response that you get to the vaccine. What, of course, is an effect of that is that you won't be fully protected until a week or so after that booster dose. When the 21 days was originally incorporated into the clinical design, my expectation was that that was probably the earliest time that they would anticipate that you could boost what is in fact a priming. And so when we talk about vaccines, we talk about a priming, sort of similar to the pump on your soap dispenser. And that primes the immune system. And then when we come in with the booster, that really boosts the antibody response to a much higher level. And so 21 days was probably the shortest period. Will 42 days be too long? I do not believe so. I honestly feel that we will still be able to demonstrate very effective boosting within that 42-day period. And so Health Canada, NACI, the World Health Organization, have all agreed that this is a very reasonable alternative strategy when there is a vaccine shortage. And I think all of us who only just have to watch the news realize that the most vulnerable group currently is the elderly, those in nursing homes. And so I think what we're being asked to do as healthcare workers is take a step back, allow that population to be immunized, while still recognizing that what we will be doing is going to be effective. It will take us a little bit longer to get there, but we will get there. And so I thank you for your understanding around that. Back to you, Erin.
Thank you very much, Fiona. We do have some time for questions. I just want to point out there are a couple of folks who have their hands raised right now, which is wonderful to see. Sheila Price, MNB, and sorry, I just gotta look. Lori, I can't see your last name right now. Just, I know sometimes people raise their hand in error, so I'm gonna go and ask a question first. And for those of you with them raised, if you do actually have a question, then great, leave your hand up and we'll get to you in 1 minute. Dr. Smale, while I have you in the hot seat, I know there's a lot of question about the evidentiary base for the extension of the second dose. Certainly professional opinion carries a ton of weight in this. Can you talk about that in a bit more detail, and also specifically, like, what if you don't get a second dose at all, or do you still have some modest level of protection?
Yeah, we're assuming that with a single dose, the protection may be in the range of about 30% against symptomatic disease. As I mentioned, it is that second dose that truly boosts the antibody response. So it is important for a robust and probably longer lasting immune response. Yes, it's there are no clinical trials comparing 21 days to 42 days. So I think we're relying on expert understanding of what is usually seen with a prime and a boost response with a vaccine. And as I mentioned, I think the 21 days was the shortest we could go. Because the goal at that point with the study was to get the immunity and the protection as soon as possible. So yes, I acknowledge that we're relying on expert opinion, but I think we do have a lot of expertise that we can draw on. And as I say, I personally feel very confident with this.
Thanks very much. So I noticed we still do have Lori Regenstrife and Mark Hewitt with their hands up. Lori, I'll go to you first. If you wanted to ask your question, you'll receive a note to unmute, and then you can go ahead and ask your question. Okay, maybe we'll try with Mark. Mark, same process. You'll receive a note asking you to unmute. You can do so and ask your question.
Hi guys, I may have missed this at the beginning, but I did hear that obviously we were shutting down the clinic for the next couple of weeks. We're expecting some more doses sort of mid-February. In regards to the framework of vaccinating people within 42 days, there's going to be a significant amount of people that their 42-day mark is February 18th or 19th based on sort of when the clinic opened up fully to all the P1 or first sequence individuals. So what's the contingency plan for those individuals if we're only getting doses, presumably that week or around that same time, mid-February, for those people to get it within 42 days?
Erin, do you want me or Bruce?
Oh, I can certainly take that. Thanks very much, Mark, for the question. And it certainly does highlight that there are challenges with an uncertainty around continued vaccine supply. And that's a challenge being faced across the country. So at this point, the dates that we know of the supply we'll be receiving or that we're not through the next few weeks take us to a point where we can begin to deliver our second doses within that 35 to 42 day period. We will have to continue the work and the advocacy to ensure that additional replenishing supplies come available in February. And I know that certainly our president and CEO meets very frequently along with other CEOs and chief medical officers of health with the general and the task force to highlight the importance of that. There is not a contingency beyond the extension until additional supply is available, Mark. So at this point, we know that our supplies allow us to deliver a significant number of doses within the 35 to 40 day period. And we believe, according to reports, that Pfizer should begin to continue to return to its deliveries in mid-February. Until we have that verified, we don't have other contingencies.
Thank you.
Maybe I'll just add, it's Dave, maybe I'll just add that that was part of the overall assessment from a provincial standpoint as well. So the province is very aware of when we need our second doses, you know, sort of towards that 42 day mark for all of those that we've given a first dose. So that's where, if it came to it, perhaps there could be provincial reallocation as doses start to come in, but they're very aware of what we need and when we need it. So so that's firmly on the front burner.
Maybe, Erin, I could just add that the planning that is currently in place is based on a more conservative estimate of doses to be received by the province than the federal government has provided. So we think that we've planned for the worst case scenario. Of course, we could be proven wrong, but I think it's fair to say there's more upside in terms of the supply chain than downside based on the planning assumptions that have been made. Now, I mean, everything could go to hell in a handbasket. That's true. But I think it's also important to say the assumptions we've made are very conservative about the supply chain between now and the middle of February.
And so I guess with that on the table, it's fair to say that if we were to receive more supply, then we would accelerate our actions and trying to get everyone squeezed in as soon as possible.
Absolutely.
Yeah. Good stuff. Leslie, I know you touched on it in your presentation a little bit about the process for sequencing as we move into this next period of vaccination. There's a number of questions related to, you know, I guess those that maybe shouldn't sequence themselves inappropriately or incorrectly in the first round. I know you answered this, but could you just underscore the fail safes that we're looking at for round 2? And what does that mean in terms of sequencing for the secondary dose?
Right. So the sequencing dose is timed to your first dose. So we're not suggesting if you were sequenced in group 1 and you really belonged in group 3 that you're going to wait until group 3 is done. That's not on the table. So you will be scheduled based on the timing of your first dose. If you think you've sequenced yourself in the incorrect group, you can go in and go cancel back at hhsc.ca and put in a cancellation. Likewise, and I'm looking for Michelle LaFleur to tell me I'm 100% right. If you put in a second request, it will delete the oldest and take your newest submission. So we'll just confirm that Leslie's got that accurate, but I'm pretty sure I do. So there's 2 mechanisms. And then the third is we're going to go in and look in a filter at if there's a unit, a team that was intended to be in sequence 3, and we're seeing a large cohort in sequence 1, we're going to look at it. Can we just move those lists? So we will confirm that plan as it happens, so people know where they're sequenced. I did see a question of how far are we through sequence 1, and of the just over 4,000 HHS staff and physicians that have been vaccinated or learners, well over 3,500 of them, and that's a high level estimate from us, were sequence 1. So we did start to do some sequence 2 on the weekend, but the majority of our doses where we put needles in our team have been people from sequence 1.
Gotcha, thanks. And 2 questions here about the technicality. So if one doesn't get their second dose within 42 days, if that was to happen, could they opt out? Or if they were to be offered one, excuse me, within the 42 days, could they opt out and wait for a single dose vaccine to come along? Would that be recommended in any event?
I would not recommend that. I think we know that the second dose will boost, and so I would recommend that hopefully within that 42-day period that people are willing and comfortable accepting the booster dose.
And just to confirm, for those that may not get it, if it was to come to pass that we didn't have the supply, someone didn't get it in 42 days, so they have to start over again and get both doses again?
I knew that question was coming, and I think we still don't have those data. Let's keep optimistic that we're going to be able to achieve those doses in 42 days. And if we do need to come up with a contingency plan, we will have the best minds onto it and come up with the best strategy.
And there has been some questions raised variously about whether or not we should be vaccinating, prioritizing those that work in units with a preponderance of LTC residents on the unit, and as well sort of the, how does that fit within the broader public health decisions to prioritize LTC, yet there are hospital spaces that we know have a number of LTC residents. Leslie, can you speak to that a bit?
Yeah, so if people recall, the second group in sequencing are those teams who care for patients who are at the highest risk if they get COVID. So at a minimum, the sequencing framework puts the teams that are dealing with vulnerable patient populations, including long-term care and complex care, into sequence 2. There also has been signals that we will start to vaccinate our long-term care patients. So we're going to work on that process. And then at any time, and this is how this all fits into the big picture, we need to remind ourselves the vaccines are a provincial resource, that the oversight for this is very much partnered, as Bruce spoke to, with public health. And public health could give us direction to target a specific team or a specific group of team that are caring for long-term care people or frail elderly people, and we'll take that direction as it's given. So for sure, they're considered right now in sequence 2. Behind our highest risk teams is our most vulnerable patients. And again, in the community sector, the most vulnerable patients are still the overall provincial priority.
Understood. And as patients might be transferred from a high-risk retirement home or an LTC to hospital, do we know if they've been vaccinated? Do we have that information at our disposal? First dose, second dose, any dose?
Yeah, so so for sure, everyone who gets vaccinated is in the provincial COVAX system, and you have line of sight to where they received their first dose and which vaccine they had. One of the processes that we're working through right now is how we're going to work with long-term care and retirement home. If people come into our organizations, how do we ensure we vaccinate them in the right time frame? So that work's underway.
And a question about the balance of energy that will be applied in the clinic. If we were to get an influx of doses, and then now we're able to do second doses that have been delayed, so we have to do a backlog and start administering first doses, what's the capacity plan to make sure that we can do all that at the same time?
Well, thanks, Erin. I mean, really some remarkable pivoting by the teams and even setting up the clinic. Folks may recall we went from doing sort of 31 in the first day, 300 over an 8-hour period in sort of day 3 and day 4, and then we were up to very close to 1,000 in a 12-hour day. So the team has shown that they're pretty great at being able to optimize workflows and create capacity. And so the plan and the work really is happening right now to further develop mechanisms to allow us to be able to flex up if there is a significant influx of vaccine and get as many second doses, and where we have authorization first doses in as possible. So exactly whether that will be, expanding the hours a bit further or expanding to an additional sites, which is in the long-term plan for public health to have several mass vaccination clinics. But in the short term, whether we would do that or we would also just look to use efficiency to allow a few more people to get through. All of those are in the cards. So I think we all look forward to having that opportunity to be working through how to get more vaccines into arms because the supply is there.
Great, thanks. Maybe Les, did you want to add to that? Sorry, I see you've gone off mute.
Oh, no, sorry, I just never shut it off.
That's usually my cue. Don't do that. Maybe just one in summary. I know there's tons of questions here. We want to get to them all. We will do our best to try and carry some forward to our Thursday town hall. Dr. Smale, maybe if I might, just one final question to you. In summary, I mean, a lot of questions about the evidence supporting the decision by the province. If someone wanted to read more, where would you recommend they turn to look, educate themselves about this and to try and seek more information?
So I'd recommend that you Google the National Advisory Committee on Immunizations, and that brings you up to their COVID webpage, and there you have every piece of information with all the references, including references back to the CDC and the World Health Organization. So that is my go-to for information, and I think we have to respect their opinions.
Very good. Thank you for that. So again, just in summary, I know there's questions we have not gotten to verbatim today. Please continue to send those through to the hhsnews@hhs.ca inbox. We'll use that to craft the content for future virtual town halls. We have one planned for Thursday. This topic is on the agenda again. So you can do that. And we'll try to also keep adding to the information that is available on the hub right now. So you can always go there and seek out what's there and provide feedback about what's there when you do. So Rob, maybe some closing remarks from you, and then we'll finish for today. Thanks a lot.
Yeah, thanks very much, Erin. And again, thanks all for coming. There's no doubt we are in a spot where we're having to make the best of the situation that is presented to us. I think there's no doubt if we could stay on monograph, that's what we would be doing. But we cannot do that because of things that are happening at an international scale. So, I don't want to hide from that fact. We are making the best of the situation that is presented to us, and in doing so, we are following the provincial guidance. So, the concerns that I think that are being raised today are likely being raised at hospitals across the whole of the province. Thank you for the hard questions. We will continue to do our best to answer them either on the hub or at our next town hall on Thursday, which I would encourage you to attend as well. So thanks very much all.